Um, Thank you for inviting me to give a talk in this meeting. We're going to be talking about hyperlipidemia, which is a topic that first thought we think about them when we see Goldstein and Brown, who first found the LDL receptor and got awarded the Nobel Prize. But the proof of concept that it's important was when we actually were able to transplant liver in a patient, a little-year-old girl with homozygous familial hypercholesterolemia. And for the first time, we were able to do something that we can reduce cholesterol. And unfortunately, she died from heart failure because she had a liver and heart. But this was the beginning of this whole journey. And of course, cardiovascular disease causes 37% of mortality in Saudi Arabia. And, the modifiable risk factors have been talked about earlier, a non-modified risk factor. In the interheart, of course, dyslipidemia is probably one of the most modifiable ones, and something that starts really early in life and progresses. Hypercholesterolemia is the big umbrella. Then you have familial hypercholesterolemia, and a small proportion have the very severe form, which is homozygous familial hypercholesterolemia, which is the very challenging thing that we try to address. Now, in homozygous, actually, you can have hyperlipidemia, dyslipidemia, and cholesterol crystals from birth. That's how early things can start. And when we looked at patients in a cohort in a lipid clinic, we noticed that the average age is, average LDL is 14 in these patients. And you find that CABG, coronary bypass surgery, and aortic valve replacement is very prevalent in this population. We have very severe disease. You can see arcus cornealis and xanthomas. And interesting that probably the vast majority of patients we have who have homozygous are 5 genes. 5 genes probably explain, 5 gene point mutations explain the vast majority of patients with homozygous. Now, why do we try to treat them? Because we know we can alter the course of the disease. When we lower LDL, you lower the chances of having coronary disease by 20%, and the more you do it, the better. Many mechanisms exist of how we address that. The first, of course, is the 4S study when we start with statins, and this would change the whole face of dyslipidemia management. 1994 was the big year. So this is the first time we showed that we can give a treatment, a medicine, that can lower mortality in this patient population. Since then, a stronger statin is better than a weaker statin. Then if you give a higher dose, it's better than a lower dose. And then, of course, you want to try to alter something else, which is the reabsorption. And this is when Niemann-Pick's like peptide, you give ezetimibe, and the outcome study showed benefit, but it takes longer time. Probably now the number needed is 50. And of course, the big breakthrough recently is the discovery of PCSK9. Initially started with Mendelian randomization that showed that in a group of African Americans in Texas, those who have a loss of function of PCSK9 had 80% less cardiovascular disease, even when you match them to control. And what you do, you help with the recycling of LDL receptors. And of course, when you give the trial, in the 4-year trial, we see significant reduction, 50, 60%, about 60% reduction in LDL, and that resulted in reduction in outcomes, combined outcomes versus placebo, and the more disease burden, the worse. So if you have no multivessel disease, you can see significant reduction, number needed to treat, and that's same when you see one MI versus multiple MIs. If it's recent versus an old, so the more recent, more MIs and higher burden of disease, you see more benefit. Alirocumab is another PCSK9 inhibitor, monoclonal antibody. It also reduces LDL and reduces cardiovascular events. A newer technology like inclisiran, which you go with a small interfering RNA. It's also shown reduction in LDL in heterozygous patients with risk factors and in those who have cardiovascular disease. Meta-analysis also shows that there is, shows benefit. This is not the outcome trial, so we definitely want to wait for the outcome trials, but this is encouraging. The latest one is actually the oral form of PCSK9 inhibitor, and this is now actually last week. The first trial was published, phase 3, showed that there is significant benefit in LDL with the oral form. So you have now an injection that's 2 weeks, you have an injection every 6 months, and now you have an oral form of addressing PCSK9. So why do we care about this stuff? Because we don't achieve targets. So we don't, if we just give them regular statin, it's not going to achieve targets, and that's where we are. Most patients don't achieve targets. And when we look at one of the reasons is because we don't use, as a community, combination therapy. We don't use it. We just use one therapy, and that's it. And we know, and this is data, Saudi Arabia was included as one of the countries in this study, showed that there's definitely, when you use combination therapy, PCSK9 inhibitors, that there is significant reduction in LDL. And now, pemvidoulic acid is an alternative to patients who have statin intolerant. It does reduces LDL, but we have to understand when we look at pemvidoulic acid, in the trial, we start with 130, so it's not like PCSK9. And there is outcomes, but this is compared to placebo and not to statin because these are statin intolerant. Triglycerides, fish oil has been, it's all over the supplements, very popular, very bad in evidence. We have failed time and time again to show that fish oil reduces. So we tried it in diabetic and tried prevention, no difference. But when we used EPA alone, then we saw with no DHA, this is when we found in the icosapent that we actually have significant reduction in cardiovascular events. Now, is this because of triglyceride reduction? Is it because the EPA itself reduces it? This is yet to be seen. Now, we do have a medication now, olezarsen, that definitely reduces triglyceride. Because we have 50% reduction. The question here now is, will that result in outcome study? And until that happens, the triglyceride as a target is unproven. Lp(a), a lot of excitement about it. We know it's very atherosclerotic. And now we have a small interfering RNA that reduces Lp(a) by a significant amount, so 90% reduction. Again, if we reduce Lp(a), we know it's associated with bad things. We know it's associated with cardiovascular disease. But if we reduce it, will that result in outcomes? We have to wait for outcomes. Okay. So why is there a push for having a specialized lipid clinic? Why do we need that? It's a multidisciplinary. We need cardiologists, lipidologists, endocrinologists. We need nutritionists. We need psychiatrists, psychologists. We need trained nursing, vascular surgeons, liver transplant, plastic. A lot of patients a lot of specialties have to come in to help us. And if we look at treatments like liver transplant, we can see definitely if you do a liver transplant, you can definitely reduce cardiovascular events. But it's not the end of the story, because after a number of years, what we notice is LDL starts to go up. So you can't just transplant them and have them follow up with a transplant physician. You definitely have to keep on evaluating these patients. Lipophoresis, another very important treatment, and it definitely reduces LDL, but it has a yo-yo effect. So if you just treat them, then you won't be able to achieve what you want. Now, another way of treating them is to do LDL-independent medications, like lumitibide. And in these medications definitely treat patients with homozygous, and you can see significant reductions. And we can see that also in our population. And when we look at, and this is also even effective in pediatrics. They used to be just in the adults, but now we have evidence that it's also effective in pediatrics and teenagers, which is an important arsenal. And finally, we have evinacumab. Evinacumab is the latest treatment in homozygous familial hypercholesterolemia. It definitely reduces LDL significantly, and that's independent of whether or not you have an LDL receptor mutation. So dyslipidemia has a big cardiovascular burden, reduces LDL levels, can reduce cardiovascular disease. The rate in Saudi Arabia is probably more than what we thought. Liver transplant has been successful in the young population, but comes with a price. Apheresis is very helpful, but with a lot of technical difficulties. PCSK9 inhibitor is not good as homozygous as it is in heterozygous dyslipidemia, especially in patients in our population who are mostly negative and not defective. Lumitabide evinacumab are beneficial, are costly, and significant side effects. A specialized lipid clinic is essential to deliver the highest quality of care for these sick and complex patients.